So today's session is brought to us by Vheda Health. It's titled Improving Maternal Health for Hard-to-Reach Populations. I'd like to thank Vheda Health for organizing today's session. They have been a long-time attendee and supporter of MHPA and our annual conference. So I look forward to hopefully seeing them in Kansas City next month. With that, I'll go ahead and toss things over to Shamit Luhar, the co-founder and chief executive officer of Vheda Health.
All right, very good. Thanks so much, Eric. And we will be there at the annual conference in Kansas City. We're definitely looking forward to it. So, Eric, thanks again for the very warm welcome, and we appreciate all of you who are on the webinar today, choosing to spend the afternoon to learn on today's webinar, which Eric had mentioned is titled "Improving Maternal Health for Hard-to-Reach Populations." Along with myself, I'm joined by two of my very esteemed colleagues, Dr. Deborah Jones, who is Vheda Health's Senior Maternal Medical Director, and Amy D. Dominicus, Vheda's Vice President of Clinical Design and Development. And what we're here today to discuss is really an important topic, which is on the minds of many of the attendees that are on this call today, and the states whose members you represent, maternal health disparities, right? And especially for mothers in hard-to-reach communities. And so before we get into the material, we really want to focus on a question. And that question is, how effectively does your health plan address maternal health challenges for hard-to-reach populations? Very effectively, somewhat effectively, just starting to address it, not addressing it. So we'll give everyone a minute or so to think about their response. All right. So based off of the respondees, what we're seeing here is about 3/4 of the respondents say somewhat effectively, but could improve, and then just starting to address this. So we've got a good mix here, but what this poll shows, we always like to think of this as an opportunity, and I think that's why all of us are here today. And so, according to the latest March of Dimes report, what we've learned is that 35% of U.S. counties, in fact, 1 in 3, are now considered maternity care deserts. And what that's equating to is over 1,100 counties that don't have access to any birthing hospitals, birthing centers offering obstetric care, or even OB providers. And what that is created is more than 2.3 million women of reproductive age and 150,000 babies every year that are affected by these deserts. And what's more is that 23% of these births lack timely prenatal care, with nearly 50% of those mothers not having access to the care that they need. And what this concludes and leads to is a very key problem that everybody on this on this webinar is seeking to solve, which is access to care. And that's really the key problem that we need to solve. And as we think about our populations of color, including Black and Native American mothers, especially those in rural areas, the social structures really bear the highest risks. And so really for today's webinar, what we're going to walk through is a repeatable blueprint for success. And that success is really framed around the 3 pillars that you at your health plans are really focused on improving every single day. The first is looking at how we increase engagement. The second is improving and creating a proven ROI. And then last but not least is improvements in those clinical and quality maternal health outcomes. So, with that, Dr. Jones, I'd like to turn it over to you and, ask, why is it that mothers in care deserts continue to experience care gaps? And what does that mean for the health outcomes that we're seeing in maternity?
Okay, good afternoon, everybody. Shamit, I'm excited to be here today to share the blueprint of success with our audience today. To answer your question, unfortunately, this is a complicated problem, calling for a multi-pronged response. As you pointed out, over half of the women who seek prenatal care either do not get the prenatal care that they need or have access to care late on in their pregnancy. And if you combine this with, as you said, the growing crisis of OB units closing, providers not wanting to see these high-risk patients, plus the social determinants of health that we all know about, such as housing insecurity, food insecurity, transportation issues, as well as issues with broadband and technology gaps. You can see why you have such a high risk, or not a high risk, but why you have such poor outcomes in both maternal and fetal and neonatal medicine, increasing the NICU stays, increasing long-term health impacts across generations. And these are all preventable risks. And as these preventable risks continue to increase, maternal and neonatal adverse outcomes, the healthcare system is going to bear the costs of this crisis.
Yeah. So you mentioned something very important here, which is cost. And so this is also a topic that is on the minds of many of the leaders on the call today. So, as we're thinking about costs and maternity and maternal health outcomes, why should the folks that are on this call care about solving that problem?
Yeah. Well, for a couple of reasons. We all know that the United States has the highest maternal morbidity and mortality amongst high-income nations, up to 3 to 6 times higher than our counterparts, especially in our underserved and hard-to-reach communities. And we spend more money than everybody.
Right.
As a clinician, I've been dedicated to improve outcomes, and I know many of these poor outcomes are preventable, and they're directly related to this lack of access and social determinants of health. It increases racial and geographic inequities. Having said that, I must emphasize that it's not just a clinical or an equity or a public health crisis, but it's also a financial crisis. And addressing health equity is not just the right thing to do, it's the smart thing to do. And as a result, it might result in value-based care, population health, and long-term cost containments. So I think everybody on the call today wants reduction in healthcare over time. And we also want population health and good value-based care and good outcomes for our mothers and babies who are the future of our country.
No, very well said. And among the key points that you highlighted, there was one that really sticks out, which is this topic of health equity, right? Ensuring that every single mother has the best chance to not only have a successful pregnancy, but also deliver a healthy full-term baby. And a lot of that really, starts with one of the first pillars that we were talking about at the top of the webinar, which is around engagement. And so, Amy, clearly there are models that are working. And is there a blueprint that really stands out as demonstrating, what we all want to see from a perspective of statistically significant maternal health outcomes, including average gestation at delivery of 38 weeks or greater, less than 10% NICU stay, and at least an 18 or 20% or greater improvement in delivery costs?
Yeah, so I can't say it enough. Everything in my mind, from a clinical standpoint and social standpoint, begins with engagement. And it's not just any engagement, but it has to be simple, it has to be thoughtful. And really what we want to do is foster trust with members and accessibility. And with one comes the other. It really helps to create a more unified experience with health plan partners. Not only when we're working with members in this sense and our health plan partners, does it help outcomes, but it provides access to care. It provides resources through health plans and community specific, various benefits, multilingual support, and it's all in one place. And what I find is that really humanizes the experience, which can be very numbers driven and very set apart. So creating that sense of optimism for our moms, someone's caring for them, someone's looking out for them, and we're here to help. So I think there's a big point in making that known and not just saying it, but having members feel that way. So a lot of members, I would say, the place that we start is the care kit. And that includes the smartphone. This smartphone isn't just a phone, it has a smart SIM. The smart SIM is going to make sure that we're connecting with the strongest cell networks in the area, ensuring that moms have not only cell phone access, but broadband service. So this is, whether mom is in an urban center or a rural desert, everyone gets access with the strongest access. So there's, that dedicated service. And that's just giving not only the member, but providers and care team members peace of mind. I would say it's from the kit with these pre-connected devices. So members will receive condition-based devices. We have, things such as a weight scale, blood pressure cuff, glucometer. And what they do is they automate data collection. It comes through the mobile app and it's based on acuity and it triggers live real-time human feedback. Everything at a 4th grade reading level and everything focused on not just stabilization, but re-education, making sure that the health literacy and the support to educate is there, whether that's the member and their family or with mom's OBGYN. And with that, I would say the real-time coordination specifically with the member's care team really ensures that they're involved. They're there and they can see information for key maternal milestones, making changes to a care plan if necessary or modifications. And this includes the entire time during pregnancy, as well as up to 12 months postpartum. So it's important to note that this doesn't end with delivery.
I thought it would make sense for us to walk through that member journey in a little bit more detail.
Yeah, sure. So trying to, again, show that journey in totality. We're looking at Agnes. So she is a 30-year-old pregnant expectant mom with preeclampsia. She can be referred through her health plan or her provider. Our team works quickly to enroll her, knowing the sensitivity of time and enrollment and engagement, and delivering the care package to her directly. Now, once she has that care package, we work through onboarding. This is where we'll make sure that she connects with someone from our onboarding team. Through the smartphone, she's able to learn how to use her equipment that's connected to it. as well as the Vheda app, and really make sure that the expectations are set for usage, and that she has quick access to support if she needs it. Agnes will track her vital signs. She'll answer, you saw the original onboarding assessment, but we'll also have short answer prompts at strategic timeframes and based on activities while she's participating. If her blood pressure is too high, or she gains an abnormally large amount of weight in a short period, the automated system, as well as someone from our clinical team, so a human is intervening in real time and reaching out to her. There's also prompts. So there's a number of different ways we're communicating if and when additional support is needed. Another thing I would say throughout the journey is tailored education. So we talked about the reading level, but this also includes personalized video education through a video library that again can be selected by the plan or specific to conditions or locations. It's culturally, linguistically adapted whenever necessary, and it really helps to give content not only through key points about her pregnancy, but other determinants or factors like stress and sleep, and so many other things that may be a factor in how she's doing. And throughout this time, while she's using her devices and engaging with the team, we're working to collaborate, not just with Agnes, but with her care team. So when we're reaching out in real time for readings or for program behavior, we're able to coordinate with her providers, closing gaps, if there are any care gaps, helping her not only make appointments, but understanding when it's appropriate to see her providers and why, and when it's appropriate to escalate or see someone in an urgent care setting. The thing that I really can't stress enough is the fourth trimester or postpartum support. Support does not end when moms deliver. We are continuing to encourage device usage, monitor those readings, also providing various prompts and assessments, whether that's about depression or mental health and mood, access to services now, not just for her, but her family, offering community resources when they're identified. Again, facilitating connectivity, whether that's a mental health provider, primary care provider, maybe she hasn't found a pediatrician yet, anything like that. And this is all up to a full year post-delivery, which I think is important to point out, that shift in understanding that now we have to shift to make new sustainable health habits that impact not just her, but everyone in her family, hopefully long-term in a positive way.
Okay. All right. So, I think what we're seeing here is from the perspective of Nicole in this member journey, this engagement is, fairly comprehensive, right? And that engagement, because it's centralized in one place, it makes it a little bit easier for Nicole to better manage her pregnancy and see the outcomes that she ultimately wants to see, not only with herself, but then also with, with her soon to be born baby. So, having said that, talk to us about, some of the specific touch points that a mom such as Nicole or Agnes might experience along the journey. What are the ones that kind of stick out and say, these are really important?
So after enrollment, I would say the kit delivery, we start there. Through the initial onboarding assessment, where we can identify baseline barrier needs, even before we speak, or a member of the team speaks with our moms. The daily or routine device use, that outreach that occurs from those readings is a huge touch point, and it's ongoing. And again, that also helps to fuel the feeling of trust and rapport. and re-educate or work to stabilize those readings so we can avoid, unnecessary utilization or high cost events. And I'd say then we work to tailor that, where we're connecting the dots, closing the loop, however you want to term it, with providers and provider engagement. We want to show the importance of and ensure that moms are being seen, not just for routine appointments or not just for an acute visit for a concern. Regular routine appointments, communication openly with the care team is so important. And then with that, I would say touch points come from there around clinical needs. So it could be medications. I think I mentioned earlier, but care gaps being addressed and working to facilitate closure for those. And I think throughout the pregnancy, all of these are just still working to create better access, where moms feel supported. Again, there's accessibility across the board, and consistent engagement. And we're knowing that this leads to, from perinatal to that postpartum period, moms will remain engaged and know that they continue to have access to support.
It's through this interaction that we're really seeing that engagement between the member and and their health plan through this through any sort of through a consistent maternal health program, showing what we like to dub closing the loop. And that closing the loop is really focused on integrating and creating provider engagement, because that provider engagement through any sort of medical focus, whether it be the management of a chronic condition, or in this case, the delivery of a healthy baby, the physician's input is paramount. So any engagement model that focuses on that provider engagement will help lead to not only consistent but better outcomes than we're used to seeing in the maternal health space. So Dr. Jones, with that, I want to turn it over to you and have you speak to some of the evidence that's available that outlines how and why this type of virtual engagement model is working.
Shamit, every time I see that little video clip, I wish that I had that available to me while I was actively practicing, or even today I'm semi-actively practicing, because we had to hire a whole team of people just to try to connect the patients to, getting to the right place, making sure they had their medication, speaking with them, and meeting them where they are. She doesn't write things down. She takes her medication once a day. But I'm off script a little bit, but I just have to say that's the most valuable part of this whole program, in my opinion. Now, outcomes. Not surprisingly, the outcomes that have been measured over thousands of deliveries during this virtual program have been successful. And again, that patient engagement is so crucial. Patients being able to communicate and contact their providers easily. In terms of patient engagement with the Blueprint virtual program, we've seen above 80% patient engagement. And that is a strong indicator of that centralized care that you were speaking of, via the smartphone, has significantly improved outcome. Also, travel barriers. I have patients that travel 2 hours to see me. So that is quite important. The return on investment, decreasing cesarean deliveries up to 16%, decreasing NICU admissions, and significantly decreasing preterm birth. All of these are measurable outcomes that we have. And these outcomes directly counter the current trends that we're seeing in the country. And it supports that Vheda isn't just effective, but it's essential, especially in areas where care fails to reach.
Well, from an outcomes perspective, this is fairly exciting. Fairly exciting because I think what this does is it really shines a light on the opportunities that we can create through a virtual health engagement blueprint such as this. And so, one of the things that we talked about toward at the beginning of this webinar was the topic around health equity. And so how do we ensure this health equity is not just a one size fits all as it relates to outcomes, Amy?
Yeah, I can answer that very simply. When we talk about things and customizing the package based on conditions or language, or these assessments that identify barriers and focusing on those for the individual member, every step is individualized. So it not only is it not a one size fits all, but when we track disparities, we're able to really adapt interventions with context. So that can be from the education library to whether the mom wants to be messaged certain things or have reminders in a way that makes sense to her. And so any step of those supports can also be modified specifically for that member. We also, I would say, very much utilize data, and this will help us be proactive, making sure that we really target the highest need or risk moms, and also ensuring that equity is built in. It's not something that has to be done. It's not an afterthought. It is built into every step so that members do not have to adjust what they're doing to fit a model, but the model fits them. So I think that's, not being an afterthought, I would say, is probably one of the biggest things.
Okay. And, one of the things that we're starting to see now is as we go from state to state, there's now been a mandate by many state Medicaid programs around the postpartum period. And so when you think about a model such as this virtual health engagement model, how is the postpartum care included, and how are we ensuring that so that moms have the support they need after that delivery?
Well, let me just jump in first, and then Amy, you can talk about the programming. Just to piggyback on why states might have mandates for postpartum care. As we all know, 53% of all pregnancy-related deaths occur in the postpartum period. Cardiovascular disease, mental health suicide is one of the highest reasons, up to 22% of, and in certain ethnic groups, even higher, postpartum suicide as a pregnancy-related, the cause of pregnancy-related death. So the fact that the Blueprint program continues up to 12 months, because postpartum deaths occur from day 7, or even could occur earlier, but the majority of them from day 7 to day 365. The fact that we can continue to touch these patients up to 12 months if needed is is fabulous. Keeping track, keeping connected to the mother, anxiety and depression screening, continue to check on their vitals up to 12 months is, and then connecting them to either mental health providers or OBGYN providers. It's critical. And I think it's a beautiful part of the program.
Yeah.
Amy.
I was gonna say, what I can add to that is, it really helps to break the cycle of poor outcomes when we're able to have that continuity of support. Members who have been working with and understand how to use the devices, getting those gentle nudges if they need a little more support to understand why it's important to continue to check their vital signs. Also very strategic in the types of questions and the way that they're asked. We can see how they compare to previous responses with these assessments. And then additionally, we have other questions. Dr. Jones, you pointed out mental health as well as OBGYN. Have they seen their provider for their post-delivery appointment at 7 to 84 days, and now it's by the 6-month period? And do they have support at home? Supplies for not only themselves, but for baby and their family. So a lot of these, again, are, not discharging someone once they've delivered and hoping for the best. It really is that continuity. So I think that's a big thing to point out.
And I want to add, we're talking about access to care, rural communities. We want sometimes to see the patient 48 hours after delivery to check their blood pressure, after we've discharged them from delivery. How do they get to their provider? It's difficult, but if we had some mechanism in which we can say, hey, these patients, we want them to have their blood pressure checked 24 hours, 48 hours, 72 hours, trend it, communicate with us. That's like gold.
Yeah, and what I'm hearing here between what you're saying, Dr. Jones, and Amy, is this key word of continuity, right? It's how do we ensure during all the critical phases of a mom's journey during her pregnancy that she receives the right, essentially, touch points at the right time, right? And one of those key touch points is, and always has to be, with Dr. Jones, someone like you, who is a provider. And so with that, a model such as this blueprint, how does it align with the new ACOG guidance that was released earlier this year?
Yeah. Good question. I mean, it aligns perfectly. It's as if they made it for us, really, when I read it. So ACOG came out with, guidance, asking us to do personalized, equitable, and effective care for our pregnant women in an attempt to try and decrease morbidity and mortality and increase good outcomes. So we do robust needs assessment. We focused on shared decision making every step. We do real-time remote patient monitoring for access, engagement, and continuity. We deploy telehealth approach, and we ensure that mothers can access community support, and it's all data driven, right? And we're constantly improving when needed. So if you read the ACOG guidelines, it's like step by step by step what we at Vheda Health are trying to do for our maternity community. ACOG has essentially endorsed it.
Well, and it's not just Vheda or any of the other organizations that are out there, right? It's also many of the the health plans and the audience that's here today who are focused on building and delivering programs that are going to ensure that our moms have the healthiest pregnancies possible, right? So this is also, exciting news for them to hear as well. And so, what I always think about then is, and now we're in the present, how do we think about what's next? And so how do we continue evolving this this maternal health blueprint for these populations, Amy?
Yeah, so I think to keep evolving is mandatory.
Mm.
The populations and the issues and things that we're dealing with, or expectant moms are dealing with, are going to continue to evolve as well. But I would say, investing in research, looking to make even better opportunity for virtual engagement. I also think about expanding culturally competent support, based on different areas and backgrounds. It really does make a huge difference to understand the culture and the factors that are faced for one person versus another, and not read about it, but have experience with it. I think continuing to build more specifically community partners as well as technology partners, just with all of the various technology changes and upgrades and advancements. But I think we have to be committed to our members and to understand that it can be patient-centered, but everyone wins. So putting, a national standard that we can set for equity first. This is the whole person, not just their pregnancy. We want these health understandings and access to care, and knowing that they can communicate with a provider to last a lifetime, as well as throughout the maternal care.
Well, and one of the things that, among the things that you said there, Amy, is we really want to make sure that our members have the right support at the right time. And, healthcare, as we all know, is it's one of those industries where even if we look back 10 years ago, there was a really, really big push for just technology only solutions. And what we find with healthcare is that healthcare is one of those industries, and particularly in maternal health, where face-to-face interactions with an actual human, right? Whether it's a care or a case manager at at our health plan, or an OBGYN, that type of interaction is very, very strong, and it's needed. And so if you can add just a little bit of technology to complement that, you can really create, I think, what sounds like a very winning formula. So we really appreciate Amy providing that look into the future. And so, as we approach the conclusion of the webinar, now we would like to close with a question to the group. So, which is, after today's webinar, how's your understanding of how to address maternal health disparities improved? So let's give everyone about a minute or so to think about and provide their responses. All right. Well, what we're seeing here is a good majority of the folks here have said that their understanding has somewhat or significantly improved, which is great. That's very exciting to hear. So as we approach the end of this webinar here, one of the things that we'd like to invite you to do is to scan the QR codes that are on the screen. There's an accompanying white paper to this webinar that has exact same title as our webinar today. And what we'd also like to do is really invite each and every one of you to join our insider community, which would provide you access to additional content such as the information that you're hearing on today's webinar, along with blueprints that many of the major MCOs across the country are adopting. And we'll also be sharing this information in a follow-up email right after this this webinar. So with that, I know we have about five or so minutes. We'd love to answer any questions that that folks on this call have. So would love to just have everyone take a minute. If you have a question, please drop it in the Q&A here, and we'll start taking them. And we'll do our best to address all the questions that we're receiving here. But one of the first ones that I see here, Amy, is from the perspective of maternal health programs, is our program only limited to those moms that have hypertension or preeclampsia, or is it more than that?
No, it's definitely more than that. So moms who have access to care struggles, who may have had a history and be well during this pregnancy to date, looking to have preventing the outcomes as a measure. But we have a number of members who have no chronic conditions pre or throughout the gestational time period.
Okay. All right. Thank you. We see another question here. Almost seems like we might be able to combine these questions. So it's around really cultural competency and linguistics. So do we have language translation that's available for all members who use our phone, Amy?
Yeah, so we use various outlets. So we have in-house support staff for Spanish, English. We also have translation through videos, documents, and support staff. If we have a high volume, we work with our partners to make sure that we have the translation services that are addressed. The other thing that I think is important when we talk about culturally is we really do work to engage and employ members from the communities that we're supporting members in, so that they don't just have to understand third hand or second hand. They're used to it. They understand the streets and the neighborhoods, and really that makes a big difference as well.
Yeah. Well, I think that goes back to one of the themes that we talked about during the webinar today, which is we want to meet our members where they are, right? And what better way to meet the member where they are than having an individual who actually lives where they are. They understand the culture, they understand the language, and they can speak to them in a way that creates that trust and that rapport. And if you can do that, what that ultimately, and speak to them in their language, right? What it ultimately does is it creates an engagement that you're able to sustain over an extended period of time, which, for a maternal health mom, that's invaluable. This is a great question here around mothers and support for substance abuse disorder. Amy, would you be able to jump in on that?
Yeah, so that is one of the many questions, not only during the pregnancy, but postpartum. That is very important to address. There are a number of support options and communications that take place when our moms answer those questions positively. But it is very big, not only to understand history of, but current substance use abuse, as well as substance use abuse in the home. So there are so many aspects of it. But yes, not only do we screen for repeatedly, but we escalate as needed and are able to address with local and health plan and various just resources that we're aware of that need to take place.
And actually, to that point, regarding the support for moms with substance abuse, this is more of a broader question. But in terms of the clinical care staff, in addition to those registered nurses that are on the staff, could you talk to us a little bit about, the multidisciplinary staff that is focused on touching our moms throughout their maternal health journey?
Yeah, so not only do we have team members who have been in the mother-baby scenario and setting ongoing, we have doulas, we have members of our team who have been in a behavioral health setting as well as in a substance use role and providing care there. I think the sensitivity around whether there's a mental health or documented substance use abuse or opioid history may be irrelevant. This may be something new that is finally being disclosed, but being able to have support that has experience specifically there, I think is vital to supporting our members accurately and appropriately.
Yeah, very good. And we're just at the top of the hour, but we'll take one last question here. And this one's related to how a model such as this could be applied to members at an MCO. And really, there's multiple pathways for a mother to engage in a program such as this. First is through a claims identification or stratification, right? And that's done through data exchanges with our health plans, but then also a prescription or / referral by not only the health plan, but then also the prescribing provider in this case. And, this really goes back to one of those key themes that we talked about throughout our webinar, which is many of the models out there today, and maternal health engagement models in particular, they seem to be devoid of that provider integration or that provider extension. And so how do we really take a special emphasis and focus on closing that loop and ensuring that the mother's provider is fully integrated throughout the journey of that pregnancy, because it ultimately is going to lead to trust and rapport, which leads to engagement, improvements in ROI through through a delivery cost that will be vaginal versus, let's say, a primary C-section, and then ultimately the third pillar, right, which we all want to achieve, which is improvements in those clinical and quality outcomes. So seeing significantly lower NICU stays, for our mothers. Dr. Jones, didn't know if maybe there's something that you want to add.
No. And that's the backbone of the program.
Perfect. Well, I know that we're just over the top, just past the top of the hour. So Amy, Dr. Jones, thank you so much for joining in. To everybody who's on who's on this call, thank you for spending the afternoon with us. We truly understand how important maternal health is to the work that you're doing, and we really hope that from today's webinar you took away what we like to call a little piece of gold that you could take back to your health plan and work towards improving the maternal health goals, so that every single mother that you're working with not only has a healthy pregnancy, but delivers a healthy baby. So with that, thank you so much, and enjoy the rest of your day.
Thank you.